Today we're going to discuss about diabetic retinopathy. What is diabetic retinopathy? Diabetic retinopathy, people with diabetes, they can have an eye disease which called diabetic retinopathy. It is increase in blood sugar level which causes damages to the blood vessels of retina. Blood vessels swells and leaks and can stop the blood from passing through it. Sometimes abnormal new blood vessels growth, which also known as neovascularization, will happen on the retina.
Factors is durations of diabetic. Durations of diabetic is the longer the duration you have diabetics, the higher the chance of to get diabetic retinopathy. And the next is poor blood sugar level control. All types of diabetes has chances to get diabetic retinopathy, no matter it's type 1, type 2 or gestational. Third is high BP. High blood pressure also has high chances to get diabetic retinopathy, followed by high cholesterol. And even pregnancy women who develop or have diabetes during the pregnancy may have rapid onset or worsening of diabetic retinopathy. Even tobacco use also has high chances. Two stages of diabetic retinopathy. First is non-proliferative diabetic retinopathy. It's also known as NPDR. And second is proliferative diabetic retinopathy, which known as PDR. So non-proliferative diabetic retinopathy is also known as background retinopathy. It is the earliest stage of diabetic retinopathy. Some microscopic changes occurs in blood vessels of the eye from the normal fundus. It is typically do not produce any symptoms at early stage. It also progresses from mild to moderate to severe. NPDR initially characterized by microaneurysms, heart exudates, macular edema, and retinal ischemia. Okay, so NPDR has 3 stages, which is at early stage, at least one microaneurysm present. And then to the moderate stage, there is a multiple microaneurysms, dot and block hemorrhages, venous bleeding, and cotton wool spots are present. At the severe stage, cotton wool spots presents, venous bleedings is more than 2 quadrant, severe intraretinal microvascular abnormalities, at least more than 1 quadrant, and microaneurysms all over the fundus, which is all 4 quadrants. Stage is proliferative diabetic retinopathy. If the severe non-proliferative diabetic retinopathy stage is untreated, it progresses to proliferative diabetic retinopathy. This is the stage we call advanced stage. It happens when retina starts off growing new blood vessels, which is neovascularization. The fragile blood vessels often bleed into vitreous. If only a little bit bleeding happens, we might see dark floaters. If it's bleed a lot, it can block all the visions. These new blood vessels can form scar tissues. Scar tissues can cause problems with macula or lead to detached retina. Discuss about the symptoms. So, bleeding from the abnormal retinal blood vessels causes floaters. The blood visions is due to the diabetic macular edema, and also the fluctuating vision happens. Impaired color visions happens. Even a dark or empty areas in visions presents, and finally vision loss. These symptoms will happen in both now eye. The differential diagnoses are central retinal vein occlusion, macular edema in diabetes, which also known as diabetic macular edema, ocular ischemic syndrome, sickle cell disease, macular edema. This macular edema is due to radiation therapy, history of the radiation therapy, and finally is sarcoidosis. The clinical features of diabetic retinopathy. The first is microaneurysm. Microaneurysm is the earliest sign of diabetic retinopathy, which is formed due to the capillary wall outpouching. It seems to be as small red dots, and when it ruptures, it will form dot and blot hemorrhage. Dot and blot hemorrhage is formed in the inner layers of retina, but another type of hemorrhage which is formed in diabetic retinopathy is flame-shaped hemorrhage. Flame-shaped hemorrhage is in the superficial layer, which is the nerve fiber layer, so they will follow the shape of the nerve fibers and thus forming a flame-shaped hemorrhage. Next, we have retinal edema. Retinal edema and heart exudates. Actually, they are the due to the breakdown of blood retinal barrier, and this will cause leakage of proteins and lipids from the vessels. Usually the exudates are yellowish and it seems to be hard with definite shape. We can see the shapes of the hard exudates. Okay, next we have cotton wool spots. Cotton wool spots are formed in the nerve fiber layer, and it's due to the occlusion of precapillary arteries. Usually it's surrounded by lots of microaneurysms, and it will be seen as wools, like the white cotton wools. So that's why the name is cotton wool spots. Next we have veins, changes in veins such as venous loop and also venous beading. Both of this is actually the predictor of proliferative diabetic retinopathy. So when assessing the patients, if they have venous loops and venous beading, they are more likely going to develop into proliferative diabetic retinopathy, because this both is actually will be causing retinal ischemic. So retina will be getting less oxygen. So next we have macular edema. Actually, macular edema is the leading cause of vision loss in the diabetic retinopathy. So there are two types of macular edema will be known as the clinically significant macular edema. Two types are if there is any retinal thickening at 500 micrometer or less from the center of foveal vascular zone, or if there is any hard exudates with retinal thickening 500 micrometer or less from the foveal vascular zone, or retinal thickening one disc area or larger and size located within one disc diameter of the foveal vascular zone. So these are known as clinically significant macular edema, and they need immediate action to be taken, immediate treatment to be taken. And finally is neovascularization. Since the vessels are leaking and there is lots of problems in the vessels in diabetic patients. So finally, due to low oxygen concentration in retina will form new vessels, which is actually not stable, and it may cause hemorrhages. So this is also one of the cause of vision loss. Now let's see the clinical assessments needed to be done for a diabetic retinopathy. First is visual acuity. Visual acuity is a must test to be taken to any patient. In this, we are saying whether diabetic retinopathy is disturbing their visual acuity or reducing their visual acuity. The next most important is fundus evaluation. In this, we have to note the fundus for any diabetic retinopathy changes such as hard exudates, microaneurysms, and so on, and also determine the types of diabetic retinopathy, either it's NDPR or PDR. And another thing which is also can be done is fluorescein angiography. This is a helpful test to identify the leakage of blood vessels and also the edema of retina. So these are the two important assessments that needed to be done before we diagnose diabetic retinopathy.
Of diabetic retinopathy. So we have 4 pictures here with different conditions in diabetic retinopathy. The first is the mild non-proliferative diabetic retinopathy. Here we can see that there are some microaneurysms or hemorrhages here, the red spots over here, and this is hemorrhage because it's larger. So it's actually hard to differentiate between microaneurysms or hemorrhage. We can differentiate it using angiography, fluorescein angiography. So this has very less symptoms. So this is mild non-proliferative diabetic retinopathy. So now the second picture over here is actually a moderate diabetic retinopathy, non-proliferative. Here we can see cotton wool spots here. If you see it's more whitish and the margins are not distinct, it's blurry, and you can see it looks similar to a cotton wool. That's why its name is cotton wool spots. And here also we have few microaneurysms and hemorrhages here. And we have also exudates, small exudate over here. So, and we can see actually a venous beading over here, because if you see here, the size of the vein is smaller, then it's increasing suddenly, thickening suddenly, and then
reducing back and then thickening suddenly here. So this can be considered as venous bleeding also. And in the third picture here, we can see here they have lots of new vessels here. So this is the neovascularization, and hemorrhages as well. Here we have hemorrhages here, large hemorrhages. Near this also we have hemorrhages, and also heart exudate. If we compare with this, this is yellowish, and it's the margins are distinct. Also we have hemorrhages and microaneurysms. Okay, so since this has new vessels, this is considered as proliferative diabetic retinopathy. So here we can see the vein, the arteries are very small compared to the vein. And for the fourth picture here, this shows actually maculopathy, diabetic maculopathy. Why is this so? Because the exudates are at the macular area, where actually macula is 3 times the size of the optic disc. So this should be the macular area, and since the exudates are at the macular area, and this should be the fovea, so there are hemorrhages and heart exudates at the macular area. Thus this is considered as diabetic maculopathy. So these are the 4 conditions for diagnosis that you can obtain from the fundus examination in a diabetic
Management
patient.
of diabetic retinopathy. So we have 3 ways to manage the diabetic retinopathy, and because we have 3 types of complications, which are non-proliferative and diabetic maculopathy and proliferative diabetic retinopathy, each of it should be treated in different ways. So for non-proliferative diabetic retinopathy, the management is more on reviewing annually the patient, and also advise the patient to control diabetes, because as we control the diabetes, the risk to develop PDRs will be reduced, and address other associated factors, in example hypertension, renal failures, which will increase the risk of getting proliferative DR or diabetic maculopathy, because both the other two are can cause vision loss. So the second is, if the patient is having diabetic maculopathy, we can reduce it by using our laser photocoagulation. This can be only done by ophthalmologists. In this condition, we are actually treating to reduce the edema, to reduce the leakage of the blood vessels, which is causing the edema. So our laser photocoagulation, we have 2 types: focal treatment and quick treatment. Focal treatment, it is applied to microaneurysms and lesions at the center of heart exudates. Usually this is applied for the exudates, which is 500 to 3000 micrometer from the center of macula, while the quick treatment is applied to the areas of diffuse retinal thickening, which is larger compared to the focal treatment. So other forms of laser therapy, we have other forms also, such as low energy treatments, anti-YAG, which has 2 times the frequency but lower energy, so lower damage will occur, and subtracheal micropulse diode laser, which is quicker compared to this argon laser photocoagulation. So next is pars plana vitrectomy, where this is done for macular edema, which is associated with tangential traction from thickened posterior hyaloid, because if there is a new vessels, if there is any macular edema with the tangential traction, we should remove the cause of the traction first. So thus we do pars plana vitrectomy. And then the final is PDR. PDR is treated. The treatment in PDR is aimed to reduce the hemorrhages and destroy the new vessels, because it will cause vision loss. So we can do laser therapy, which is done to destroy the new vessels to prevent vision loss, and also we have to do a follow up as well after 4 to 6 weeks to make sure that new vessels are totally removed or burnt. And then we also need to have follow up after a year, to check for recurrences, because there is high chance for recurrence in pediatric cases. So if there is any recurrence, you can do further laser coagulation or chirotherapy, which is actually using
very freezing temperature to destroy the new vessels. And also we can do pars plana vitrectomy as well here for severe complications of PDR, which is associated with any retinal detachment here. So we have lots of types of treatment. The main treatment is actually laser treatment. So laser treatment is the main treatment, but for PDR and diabetic retinopathy, the aim is different. Here it's to reduce the leakage of blood vessels. Here is to damage the new vessels. So this is the management of diabetes.
The classification, which are proliferative and non-proliferative, the risk factors, duration of diabetes, poor control over diabetes, high blood pressure, high cholesterol, pregnancy and tobacco usage. The differential diagnosis, which are central vein occlusion, ocular ischemic syndrome, sickle cell disease, macular edema in other cases, Charcot disease. The symptoms, which are the floaters, vision loss, blurred vision, fluctuating vision, impaired color visions. The clinical symptoms, clinical features, microaneurysm, dot and dot hemorrhages, flame-shaped hemorrhages, venous bleeding, venous loop, cotton wool spots, macular edema, neovascularization. The assessments needed to be done, visual acuity, fundus examination, fluorescent angiography. And finally, the management, which is referring to ophthalmologists, laser photocoagulation, pars plana vitrectomy, and controlling the diabetes. So this is the conclusion with this. Thank you for paying attention.